Happy afternoon, everyone. My case is about Mrs. X, who is 40 years, working as a junior health assistant at a community health center. Married to Mr. Y, who is 46 years, farmer by occupation. They are presented with a history of primary infertility. Married for 20 years, anxious to conceive since 16 years. It's a non-consanguineous type of marriage. Coming to their menstrual history, cycles are regular, 4 days flow every 28 to 30 days, and no history of dysmenorrhea. They don't give any history of contraceptive usage. Sexual history is normal. Coital frequency is around 2 to 3 in a week. No history of dyspareunia or ejaculatory or erectile dysfunction. The couple is aware of the fertile period. Next slide, Ulfat. Ulfat, next slide. Coming to the treatment history, they have undergone several cycles of ovulation induction with the timed intercourse and 2 cycles of ovulation induction with IUI, but failed to conceive. Medical history, wife is hypothyroid on tablet Tyronorm 75 microgram. Husband is a known hypertensive since 1 year and is on medication. No history of any drug allergy. Next, coming to the investigations, ultrasound of the wife uterus is around normal size, 6.8 into 3.8 into 4.3 centimeters. Right ovary shows 1 follicle and left ovary shows 4 follicles. So it is less in both ovaries. FSH is around 8.52, slightly on the higher side. LH is normal. AMH is 0.66, it is less. Husband semen analysis, the count is around 12 million. Motility around 20%. Morphology is 1%. It is actually mild oligoasthenospermia, asthenoteratozoospermia. Ultrasound has shown grade 3 varicocele. And DFI is around 28.5%. Endometrial treatment was given and ET was 6.5 mm after 15 days of treatment.
Doctor, 1 second. We'll just okay. Finish the summary.
Next slide, Ulfat. In my case, the female factor, she's around 40 years with a history of infertility for 16 years, having regular cycles and no history of any contraceptive usage with awareness of the fertile period. She gives a history of hypothyroidism and she's on treatment. Treated for infertility previously with ovulation induction and IUI. Details not known much about the treatment. Coming to the investigations in the wife, AFC is less in both ovaries. FSH is raised and AMH is less.
Okay. So in this case, she's a case of?
She's a case of poor ovarian reserve.
Belonging to which Poseidon group?
Group 4.
Belonging to Poseidon group 4. And husband's semen parameters are?
Boats, man, mild oligoasthenoteratozoospermia.
What does the recent semen analysis, WHO 2021? Okay, 2020. What is the normal count? What is the normal motility and morphology?
Morphology at least 4% should be normal. Motility 40%. Progressive should be around 32 and non-progressive 8%.
I'm asking WHO 2020, not 2010. Now it has changed, na? WHO 2020. So you should know the recent one also. What
Total
is the
should be, I think, more than 42 now, and grade A should be more than 30.
That is progressive motility should be more than 30. And count?
15 million.
116 million. Yeah, recent one is 16 million. Okay. Yeah. So next, now you know that she belongs to Poseidon group 4. She's come to you. So how do you proceed with her?
Ma'am, we'll do certain other investigations. I would like to know about her recent serum TSH, whether it is well controlled or what. And I would like to know about serum estradiol and day 3 inhibin, ma'am. Though it's not been a good indicator, but
Why you
they'll
want to
tell
do
us.
inhibin?
Ma'am, we'll come to know about we can predict about the poor response before starting
You
the
see,
treatment.
you have AMH, you have AFC, there is raised FSH.
Or,
All these three sufficient to know about the poor response. Okay, need not do inhibin levels. Okay, so now what will you suggest to the patient?
ma'am, what about ovarian volume? No need of that also, no, ma'am. These two are
Right.
enough.
See, when you're performing ultrasound, you will have to do the ovarian volume simultaneously. That will give. So, how will you proceed with the treatment now?
Ma'am, treatment and ma'am, do we need to know about the male's evaluation of the male partner, ma'am? Or anything about, because
So
we
all
don't know.
basic evaluation you've done. His sugars
We'll
are
do it.
normal. His thyroid is normal. Everything is
Repeat.
okay.
Do we need repeat some analysis, madam?
So what you've given is a recent one only, no?
Okay, ma'am.
Here, a couple have come to you. You have done the investigations. You have found these findings. So what will you counsel the couple, and what will you do next?
Ma'am, we need to counsel the couple that it is the chances is not very good, but still there are chances, because seeing the age of the female, ma'am, she is around 40 years, and with there is a male factor also.
So you will counsel them for IUI or IVF?
Ma'am, it will be IVF because she is around 40 years, ma'am, and they have already
low volume, low reserve, with low reserve.
low reserve, ma'am.
Okay. So before proceeding with IVF, what else you want to counsel to them? About the success rate of treatment.
Ma'am, success is less because both male and female factors are there.
But male factors
Are
can be taken
reached.
care of now by doing the proper sperm selection technique.
Yes, ma'am.
Then for oocyte,
दो सब्जी दो चटनी दो
so you will come before starting stimulation for her. You will have to counsel her for there could be a poor response. Okay. So
Yes,
and
ma'am.
because of her age being 40 years, there is a slight increased risk of aneuploidy, which cannot
Aneuploidies,
be
yes.
assessed now. And then only after the success rate of the embryo transfer also will be on the
Okay.
lower side, around 40%, not 55 to 60%, what we see in younger age group. Okay. And then before starting with IVF,
बस बस आलू आलू दो मटर मटर दो मटर से दूर हो जाएगा
do you want to do any pre-treatment for her?
Ma'am, we can give adjuvant therapy for her, like DHEA, ma'am.
How
75
dose and
mg
how
per
long?
day. 75 mg per day, 6 to 8 weeks prior to stimulation, ma'am. This is prone to increase the microfollicular environment.
8 to 12 weeks is better. Okay. How it will improve the response?
And increased androgens will increase the sensitivity of the follicles to the gonadotrophins, ma'am. Follicular and more number of follicles will be recruited, ma'am.
Recruitment
Androgen.
also improves. Anything
Yes.
else other than this that you can use?
Ma'am, we can use testosterone also, testosterone patch,
Not patch.
oral
gel.
No.
gel,
Transdermal testosterone gel.
gel.
Okay. What is the dose of transdermal testosterone gel?
12.5.
12.5 mg
Per day, 12.5 mg per day you will use. Okay. How long you will use this?
Previous
Ma'am, for
starting
around
from
2
the
weeks
treatment.
prior to stimulation, 2 to 3 weeks.
Yeah, 3 weeks prior to that, at least for 21 days you'll use this minimum. Even up to
Yes.
4 weeks you can use. Okay.
And we can give antioxidant also, ma'am. 3 months prior to stimulation.
Okay, so
Increases
patient
the
has
oocyte.
come 40 years. Will you ask her to wait for 3 months and
No,
then
ma'am.
start
Yes.
the stimulation?
We can
You
give
can
for
give her
1
if
month.
she, just for one cycle, give her all these pre-treatment, but you can advise the transdermal testosterone gel because that 3 weeks is sufficient. And then anything else?
This is the adjuvant therapy.
You can plan pre-treatment to
Growth.
get more synchronous cohort. So what are the pre-treatment
OC pills or
options?
estrogen, ma'am.
Sorry?
We can give OC pills or estrogen one prior one cycle, ma'am. For a current
Okay, how long you want to give OC pills?
for one cycle, madam, for 21 days.
See, in poor ovarian reserve, prolonged use of OCPs can further suppress the ovary. Okay,
Yes.
it is better. Minimum of 15 to 16 days could be sufficient. Okay.
Okay.
And what is the idea behind all this pre-treatment?
Ma'am, to increase the response, ma'am, for our when we are doing the stimulation.
Using androgen treatment will
Synchronize.
increase the response. If you are
Yes,
using an OCP for pre-treatment,
We'll get a
how
uniform
Increase
for
the cohort.
Synchronize the cohort.
to synchronize the cohort. Then how Easterbed pre-treatment? How do you give Easterbed pre-treatment?
Ma'am, we give in the previous cycles for 2 weeks, ma'am.
No.
From
No,
day
which day you
20.
want to start?
From
Sorry,
day
ma'am.
20 of the previous cycle, I think.
And then?
Continue till day 2 of periods.
See, before starting Easterbed pre-treatment, you should be sure that patient has ovulated that cycle. Okay. So
Yes.
you will start from day 20, provided she has ovulated, then you will confirm and then start on day 21, Easterbed dose.
Ma'am,
2
4 mg,
mg
ma'am.
BD.
2 mg.
2 mg
For
BD.
how many days?
12 days, I think.
Maximum of 10 days. But by
Okay.
then, if she is ovulated, definitely she'll get her periods. So with the onset of periods, you will stop the Easterbed tablet.
Okay, ma'am.
Okay. So how Easterbed will help in giving you a synchronous cohort?
It will decrease the FSH in the luteal-follicular transition phase.
Yes, that's how it will not allow early follicular recruitment to happen, and therefore whatever you get on day 2 will be a synchronous cohort. Okay. And anything else that you can use pre-treatment other than Easterbed and this thing OCPs, you can use even norethistierone. For norethistierone, you will start again from day 21 of the previous cycle, given for 5 to
For
7
7
days.
days.
Yeah,
Yes.
7 days. After stopping, once she gets her periods, you have to do.
Okay.
See, for OCPs, norethistierone, there should be a washout of at least 3 to 4 days. What do you mean by washout period?
We should give a gap, that is
There is a
Yeah,
gap.
there should be a
One
gap
is
of
not
at least 3 to
gonadotropin.
4 days
4 days.
to bring down the suppression.
Sure.
Okay. Yeah. What
Yes.
protocol would you prefer in her case?
Ma'am, we can prefer, we usually, we are giving nowadays GnRH antagonist protocol, ma'am. Even agonist long protocol also we can go ahead because there is no difference, madam, actually.
Okay. And anything else in agonist?
Ma'am, flare protocol, short protocol, or even microdose flare protocol that has given good results, ma'am, in poor responders.
Okay. So suppose you're starting with the antagonist protocol. What will be your starting dose in this case? Say
Ma'am,
her weight is about, she's 55 kgs.
Yes, ma'am. And she's around 40 years, ma'am, poor
Yeah.
result. We can
Yes.
start with 300, ma'am. 300 international
300 of what?
of HMG, ma'am.
Direct
Recombinant FSH needs to be used.
300 of recombinant FSH.
Ma'am,
And then
HMG, ma'am.
HMG only. We
you need
LH.
LH supplementation. Either you go with complete direct HMG stimulation, or you can combine
Or
even RFSH
Sir.
or RLH also if the patient is affordable, or you can use a combination of RFSH with HMG combination also.
Okay, ma'am.
Okay. Yeah.
Yes.
And then so you have started. So your next blood test and scan will be on which day?
Ma'am, we'll start from the 3rd day, ma'am. Second or 3rd day. So after 5 days, madam.
Oh, after 5 days.
5 days.
So you're saying on stimulation
Day
day
7.
5, stimulation day 7, you'll check for her estrogen and do the first scan.
Yes, ma'am.
Stimulation day 4.
Day 5,
Day 4, I think.
Day
After
4.
2 days of drugs.
Yes,
So
stimulation day 4.
Okay, stimulation day 4,
of
you've done the
medicines.
scan, and then you see that the follicle one is about 12 milli, one is about 10 millimeter, rest all are about between 8 to 9 millimeters. E2 is about say 180. So what will you do that time?
Ma'am, we can give
Continue the same dose.
we can continue the same dose, madam, till the follicle is around 14 mm and E2 reaches around 300.
So same dose you'll continue. You can even increase the dose if you see delayed response. Okay. And then the next day you see that you'll increase the dose little bit and it will go to 375, and you see that the follicle, there is one 12 mm, one is 11 mm, the rest are about 10 millimeter. E2 is 350.
Ma'am, then we can give the cetrorelix 0.25 mg, ma'am.
You will start your antagonist and
Start
continue the same
antagonist.
dose.
Yes.
So
ma'am.
what is the kind of trigger you want to use here?
Ma'am, because it is a poor response, we can give HCG, ma'am. 10,000 I can give.
Okay. And anything
Uh,
else? Any other trigger that you want to use?
Dual trigger, ma'am.
How do you give dual trigger?
Ma'am, after 12 hours, we can give GnRH also, ma'am. After 12 hours, we can give GnRH agonist.
No, that is not dual
We
trigger.
give together both the triggers. Same time.
1500 mg of HCG along with
No,
diploid.
not 1500 mg. Not 1500 units.
6,500 international units. 6,500 Ovitril.
If you're using Ovitril, you will use 250 microgram of Ovitril plus 2 mg of leuprolide. Or if you're using HCG, you can use 2 mg of leuprolide and 5,000 units of HCG, urinary HCG, together to give the trigger. So, what does the evidence say when you compare dual trigger versus HCG trigger?
Ma'am,
Dual
there is
trigger.
no difference, ma'am.
No. Dual trigger.
Dual trigger is always better. Yeah.
There is FSH rise also and there is LH rise also.
Dual trigger is better in getting
better number of M2 sites are seen
Yes.
with dual trigger when compared to
a single, HCG trigger or going with only leupride trigger. Okay.
Okay, ma'am.
Suppose if it is an agonist protocol, say you're planning for a microdose protocol. So how much of GnRH agonist will you give? And from when do you start?
Ma'am, GnRH agonist, usually in microdose protocol, we give a less dose, ma'am.
How
Leuprolide,
much?
40 microgram twice a day. We start from day 2. And from day 3, we start with gonadotropin, HMG, ma'am. 300, around 300 to 450.
Okay. And then?
Till the day of the trigger, we give, ma'am. Till there is a good size follicle.
Okay, fine. And what is the type of trigger that you can use here, that you would want to use here?
And we can use HCG only, no, ma'am, because
you can't use dual here. You'll have you can't use dual also. It has to be only HCG
only
trigger.
Only.
Okay. And then?
Ma'am, after the trigger, the oocyte retrieval around 35 hours we need to do, ma'am.
Okay. Okay, fine. Now, what would be the sperm selection technique here?
Ma'am, we can go for, because it is 2%, density
1%
gradient.
it is.
Density gradient.
It is 1%. DFI is 28%. Count is 12 million. And motility is?
Motility is 12, ma'am.
No, motility is 12. Huh? You can go back to the previous slide.
Motility is 20%.
20%, I think.
20%. So how do you want to select the sperms in this case? You have options. Either you can use ejaculate sample and do a DG method, or you can plan the magnetic assisted cell sorting. You can plan PESA. Which one you want to choose? Ma'am,
ejaculate with the density gradient. Because
why not max and PESA?
Affordability of the patient, ma'am.
No, that comes secondary. First, you have to look for what will give you the best results. So in this case, we are saying one is he has got oligo. The count is 12 million. Second thing is the morphology is only 1%. Third part is the DFI is 28%, which is increased. And he's already 46 years.
46 years.
So, yes. Using ejaculate that can further compromise the embryo quality. So it's better you plan for either max or you can use even PESA. Considering grade 3 varicocele, even PESA would be a better option here. Okay, so that will give you low DFI sperms and better morphology sperms, and then you will perform ICSI or IVF.
Ma'am, ICSI, ma'am.
ICSI only. Okay, so after that you will look for embryo culture and you'll decide on the embryo quality. So you
Yes,
want to
ma'am.
plan, suppose you're planning for dual stimulation. How do you want to proceed? Double stimulation.
We can give GnRH antagonist protocol in each cycle, I mean follicular phase and in luteal phase, ma'am. We start with 300 international units of FSH in the follicular phase, then give cetrorelix on day 6, ma'am.
How do you do the same antagonist protocol? And then next, what will you do?
GnRH trigger we give, then after the follicular maturation. Then after that, in the second, after the oocyte retrieval, we'll again start with HMG, ma'am.
When do you start?
Around 225 international units per day.
When do you start?
Following pickup.
After the oocyte retrieval, madam. After
Today
20
you've done the OPU, tomorrow only you'll start the stimulation?
No, ma'am. 2 days
40
gap should be given, wherein those 2
After
days you have to put them on
2 days.
ibuprofen for suppression. Later
Yes.
you have to restart the second part.
Yes.
After
And later, yeah. And later on you'll do the scan. Look for any, for at least a minimum of 2 follicles you should be able to see in each ovary, at least in one of the ovary. Only then you will start the stimulation. And here you'll be using only agonist trigger when you're planning dual trigger.
Yes.
I mean, sorry, when you're planning double stimulation. What is the advantage and disadvantage of double stimulation?
Double stimulation, we get more oocytes, ma'am, in both cycles. So more zygotes and more blastocysts with a single stimulation cycle.
In singles, the only thing is it is time less compared to pooling cycle. It will give you the more number of oocytes in the same cycle. But what is the major disadvantage of this? Cost of the cycle is high, and also second oocyte retrieval might be difficult because of the corpus luteal cyst that is formed. So technical issues can arise in double stimulation.
Okay.
And cost will be double. Not big. In the same cycle, they'll be paying twice. So the cost of the cycle will go up. And are there anything else and any other test that you want to consider? Suppose say you've got about 5 oocytes, all 5 are M2s, and then you've proceeded with ICSI, you've got all 5 grade 1 embryos. Would you want to suggest any other test? Because she's 40 years. PGTA can be considered, or even non-invasive genetic testing of the embryo from the spent culture media to rule out any aneuploidy of the embryos. Okay.
Yes, ma'am.
Okay. Suppose okay, then how do you proceed with embryo transfer in this case? You want to do a fresh transfer or a frozen transfer?
Frozen transfer.
Why frozen?
We can go for fresh also because we are given HCG.
You would have given HCG trigger, and even the estradiol values at this age will be less only. If the estradiol value is less than 2500, you can still consider doing a fresh transfer, provided the endometrium is good at the time of giving trigger.
Yes.
Okay. Yeah. You can just present your further slides, doctor.
Ma'am, I've not done more of the presentations, ma'am. Only the case slides I had done, ma'am.
You're only the case slides. Okay. Then.
Yes.
Yeah.
So in this case,
tell me.
What about the embryo transfer, ma'am? They tell day 2 is preferred in poor responders.
No. If you're getting good embryo quality, go with day 3 or day 5 transfers only. Either day 3 or day 5, depending on the embryo scoring. But the day 2 transfers, when you see which is slow growing, where the embryo quality is poor, only then day 2 transfer. If you look at the pregnancy rates, definitely day 5 transfer is best, then comes day 3, and then comes day 2 transfer.
Yes.
Okay. So in this case, the transfer would be either day 3 or day 5 transfer. Even sequential transfer would be beneficial.
Okay.
Okay. Because by doing day 5 transfer, when you keep for blast culture, if they are aneuploid, they might not form blasts. So you will know which of them are going to grow. Then you can choose the best.
Yes.
Okay. Okay then. Any doubts?
That's all.
Okay. So we'll end the class for today.
Ma'am, so just one doubt that in the pre-treatment part that you told us, only in patients with anovulatory cycles, we don't have the option of estrobet. We can only give norethistron or oxytocin.
Yes, because the withdrawal bleeding will not happen. So she will not get her periods. You'll be continuing the estrobet and she might not get her periods. Na? So only if there is, if she's ovulated, there will be progesterone withdrawal. Because of that, she'll get spontaneous periods. And with that, you can stop the Estrabet tablet.
So only 2 weeks of OC pills would be enough in such patients.
Yes, 16 days would be sufficient. Any other doubts? Okay.
Thank you, ma'am.
Thank you.
Thank you, ma'am. Thank you, Chinmay, ma'am.